All right, everybody, you ready? Because I'm a law professor, I will call on you. So the more quiet you are, the less likely I am to bother you. No, we don't really do that in law school in clinic. So in any case, I again have the absolute wonderful honor to introduce a friend. Dr. Carlo DiClemente, who, again, I could stand here all day and give his introduction, and he said, keep it really short, as if I can keep, a decades-long career really short. But just a couple of the highlights, awards, accomplishments, far too many to mention here. Probably one of the hallmarks of Dr. DiClemente's career is his involvement and in the creation of the trans-theoretical model of behavior change, which that's part of what you're going to be hearing about here. Here's some claps for people who know what that is. Yes, when I talk about it and people go like, oh, Dr. DiClemente, and I'm like, he's like a superstar in that field, and I don't, as a lawyer, I don't quite get it, but I try. In any case, more than 150 publications, which for those of us in academia are like, wow, okay, we bow to you. Appointed to the National Institute for Alcohol Abuse and Addiction in 2015, awards from virtually every entity you can imagine, Robert Wood Johnson Foundation, American Psychological Association, et cetera. There's others I'm not going to list. What I find most entertaining is that in 16, did you retire? Which one? In 2016, he retired, but he doesn't understand what that means. I don't get it. I remember there was a retirement event and announcements about this, but I don't see him any less. And that's because he is still a professor emeritus at UMBC in the Department of Psychology, where he has mentored, I don't even know if you know how many master's and doctoral students who really, I know many of them, and they have all received such an amazing experience studying with Dr. DiClemente. But he is still running 3 centers at UMBC during his retirement. The one I can specifically mention, MD Quit, is the Tobacco Cessation Resource Center, and that's how Dr. DiClemente and I work together most notably. So again, a friend, a colleague, and a superstar in his field. The pleasure to introduce Dr. DiClemente.
Thanks, Debbie. Thank you. I appreciate that. And clapping before a talk is an act of hope. So we'll see what I can do to kind of get this going here. I also am really pleased to be here and to be part of kind of talking a little bit about collaboration and integration, though you just heard a wonderful kind of display and implementation of collaboration in terms of the work that's being done in Charles County, and that's great, or Calvert County, sorry. I do a couple of things that I wanted to kind of just mention. So one of the things that with the OOCC, every county has an opioid intervention team. And so I've been working with the Department of Health to kind of work with them to help them understand the whole idea about stages of change, and how even if people are in pre-contemplation, you need to be working with them and doing something with them. So that's really where the harm reduction piece comes in. Today, though, I'm going to really talk more about our work at the Home Visiting Training Center and a project that we are doing called Substance Exposed Newborns Training that we are doing across the state of Maryland. So I'll tell you more about that as we go along. I have no conflicts of interest. The program I'm talking about has been funded both by the Department of Health and the Maryland Department of Social Services, and the UMBC training team and lots of other people contributed to this. So I want to make sure that we give them also the kind of things. What I want to start with is I think the idea, and I think you already heard that, and both of us actually have a Rachel, so I'm not sure. Not all substance-using women are named Rachel. Okay, I just want to state that from the beginning. But I think the important thing is what does it take to really kind of make recovery happen? And I think you heard that from the first Rachel, and I hope you'll hear this from this Rachel as well.
When I think back, I think that, and I'm going back to the courts a little bit here, but when I got into the jail and I went into this cell that was completely filthy, and not in living conditions that I even lived in when I was using. And I took a deep breath and felt safe. That's the exact moment that I knew that I needed to do something or I wasn't going to continue to live on. So I had what some people would call an aha moment, where it was I felt safe for myself at that point. Other influences after that point would be, of course, the Safe Harbor program. My counselor was amazing. Not only did I work on things about myself, my self-esteem that had depleted completely, especially being a mother who was using and felt like I wasn't able to quit, even though I wanted to. My self-esteem was completely depleted. But she also did family sessions with me there, which helped me work on the relationships that I had severed while I was in active addiction. Like I said before, networked. So I met people, and especially women in the AA program, which is going to be a huge influence on me later to remain sober. I met my sponsor there, who I continued to work the 12 steps with after I left. And then after that, I also met a church that actually housed me in their parsonage and created a program so me and my son could have more than we would have ever had coming out of a program like that. And also Healthy Families. They linked me up at Safe Harbor with Healthy Families, who I actually became very close with my worker, who not only taught me the fundamentals of raising a child, but she was also there to just listen and be a friend when I needed it, which was really nice to have. It wasn't like she was there to just do her job. She was there to be there for me and was really, I had people on my corner, so it was really important.
Like
so,
nice system.
yeah, those are the big influencers for me. Of course, my son, but sometimes he got on my nerves too, so I can't.
Yeah. Let me put back up here.
When I think back,
There we go. So I've been doing this program and learning more and more about opioid use, mothers and children, and trying to kind of share that information with a lot of people. And the wonderful thing is actually a number of the people in the room who you'll hear from today or have heard from have contributed to this program. And I'll explain to you how that happened. So what we need to think about is substance use, and more specifically opioid use during pregnancy. It's really a complex chronic condition, and I think you've heard that already. Substance-exposed infants and children, as they grow up, suffer a variety of complications, both in the neonatal, in the early childhood, and later development. So if you're thinking about caring for these women and children, it involves multiple providers and services, and you need integrated care. So we're focusing much on opiates today, but remember, and I was really glad that you brought in the smoking cessation piece, remember that the fetal and newborn health is also affected by a lot of other substances. So nicotine, cocaine, other psychoactive substances all have an effect on the child in fetus as well as postpartum, okay? And for God's sake, don't forget alcohol. Because FASD now, the new data actually shows that there might be 5%. We used to think it was a minimal percent, even less than 1%. New data is showing that if you take fetal alcohol syndrome disorders as a larger perspective, you will see that up to 5% of children may have experienced this. And so we need to kind of also be aware of alcohol. And alcohol doesn't come out in the testing of the baby, okay? So you don't see it in a lot of those things. So, substance-using pregnant women. Remember what addiction does, because this is the challenge that these women are facing. And there's neuroadaptation, which means that the substance actually changes the brain, okay? And why we're using MAT and trying to kind of get these women on MAT is because those brains are very much used to having the opiate. And we need some other kinds of things to help them in order to kind of get off those opiates and help them with the recovery, the brain recovery that happens in the long term, okay? There's impaired self-regulation. So as you heard Rachel say, I wanted to quit. She actually tried to quit and was off for maybe a day before she went back early in her pregnancy, okay? So there's impaired self-regulation, which affects decision-making, planning, follow-through. You have to have patience to work with these women. And you have to work with them and support them in terms of that self-regulation. That's why it's really important to have a center where they can come to and have a space where they can go and get a lot of the services. The last thing is salience. These substances become really important reinforcers and part of those individuals' lives, okay? And these substances reduce pleasure in other activities. So basically what you have is why these are so important, and that's why it's really important to understand that these women, when you say, okay, well, I know they come up and say, well, gosh, they're pregnant. They shouldn't do this to their babies. This is terrible. Well, this has become really important, and we'll give an example of that a little right here. So this is a mom discussing her loss of control. She said, I know I was a terrible mom. I knew I didn't want to be. I just didn't know how to be a better mom. Many times when my kids would be asleep, I would be getting high. I would look at them in their crib or on the mattress and tell myself, this is really going to be the last night. I'm going to tough it out tomorrow. I'm not going to do it. And then the next morning when I wake up and I'm flip-flopping on the floor like a fish out of water, all those thoughts are gone. I just knew I had to get doped to not feel that way. That's the only thing that was in front of my mind, is how terrible my body felt. It overpowered everything and anything else. So I think it's really important to kind of have that experience and understand that. So what are these women facing? Well, you've heard some of this already from a number of the speakers. Certainly stigma, certainly prejudice, lack of support, and many of us have talked about it already, fear of losing the baby. But they also are facing trauma. Many of these women have been abused. Trauma in this population is over 50%. A PTSD is over 50%. Trauma is even larger than that, having trauma experiences. So these women are facing that and other medical and mental health issues, as you heard from the case that you described very in depth there. There's also the whole internal process of guilt and self-loathing and self-esteem, low self-esteem, familial conflict. Many of these women are young. You saw that the youngest women are the ones, these are teen moms. So they don't have a lot of kind of resources, and they have usually a lot of family conflict, partner abandonment. And they also have legal issues. Some of them, most of them not about the pregnancy, most of them with other things that have happened to them. There is the lack of education, access to resource, they have little social capital, and they have lower SES. So basically, these women need lots of resources, and that's why you need a kind of comprehensive perspective on them. So when you think of the needs of the mother, obviously there's lots of needs up here in terms of housing and recovery and trauma and mental health and other children that are in the household. Domestic violence, they have social and addiction services needs, and they have skills and motivation, okay? And again, the pregnancy just complicates the needs of this person when they were not pregnant, because now you have all of the prenatal care, obstetricians, medical care, the hospital delivery system, the NICU, all of these interact with these women. And as you heard, all they need is one person in one of those settings to treat them very badly, and they will avoid this care. And then you need kind of the psychiatric care, the addiction treatment, the management specialists there. And in the postnatal period, there's the parenting, there's the fathers, there's safety, there's child development. There's all of these challenges for these women who often are ill-prepared. They're all immature themselves, and they're ill-prepared to kind of deal with the needs of the child. And so there are a number of programs around that are working with them. You have the social services, you have infants and toddlers, which is our early intervention program here in Maryland. You have the McVie home visiting, and you have early Head Start kinds of programs that are there, and you have medical care that is ongoing and needed. So this is a multi-dimensional set of problems and issues. And so how can we really address all of these issues and address all of these needs? So there are many programs out there, and you've heard the list from what you saw out there. There's a lot of programs out there. It's kind of how do you get access to those programs and how do you coordinate them like they're doing in Calvert County. There's multiple providers and programs, and that's great. But it's overwhelming to the person who's sitting in the middle of all of those programs and problems. And they just, they're overwhelmed by all of the things that are happening to them. And many of you know who have had children that pregnancy and postpartum period, there's a lot of other stuff going on that you're all worried about and that's happening in your life that makes life challenging just even without the substances and all the other problems that are there. So we created this program called Substance Exposed Newborns, a training program. It was funded by Marilyn McVie, Mary Lacasse, and Rena Mohammed got together, and we had a phone call, and they asked, could you design some kind of a program that would help us kind of build some collaboration and also kind of help our workers understand the substance-exposed moms and newborns. Okay? So it was developed with a multi-agency and provider focus. So we originally were going to have the McVie and the DSS workers come together on a regional basis. We realized, well, actually, the other people who walk in and out of the doors of these women are the infants and toddlers programs. Because if you are diagnosed with NAS, infants and toddlers programs that are all through the state also have to evaluate this child because they evaluate for developmental delay and other kinds of issues that are happening with the child, and they provide services. So there's a number of individuals and different types. There's physical therapy, there's all kinds of different specialists in the infants and toddlers program. And the interesting thing is all of them have a home visit component with different eligibility criteria and different services. So they're out there, and sometimes some women have described kind of, there's a revolving door as to who comes in and who comes out in terms of visiting them and dealing with them. The amount of coordination, communication, and collaboration among them differs by county and region. So again, I think Dr. Polsky is being somewhat modest in saying he doesn't know why these don't happen in a lot of places. It's a hell of a lot of work to put all of that together, to bring these people together, and to have people collaborate and coordinate services is not easy. And there are efforts at each of the county levels. We have gone around to multiple regions around the state, but the collaboration really differs, and the amount of collaboration and knowledge. So we were going to take on that challenge and kind of look at that. So what did they need? Well, we felt that they needed actionable information from a wide variety of providers and disciplines. And we weren't going to be able to go around the state into different regions and bring Katie Mark and Chris Welsh and all the people who we interviewed. So what we did is we did interviews with a multidisciplinary group, obstetricians, pediatricians, treatment providers, all various kinds of DSS folks, agencies. So we interviewed those folks, and then we videotaped some of them to create to become part of our training program. And so we would have these disciplines talking to these providers using this kind of method of kind of bringing them to the providers. The training, we had to make sure that it was promoted collaboration but didn't overburden. Okay? So what we provided were online modules. We have 7 online modules that the individuals take before they come to a training day. We believed that the training day was really important because we wanted an in-person regional training day to bring providers from that region together. So this brought in DSS, ITP, and home visiting providers all together in the same room. Okay? And we wanted to promote communication. So we have what I call multidisciplinary setting. When you came into the training, we assigned a table to you. So you couldn't sit with your friends and buddies and all that other kind of stuff. You had to sit with somebody from other organizations. And actually, that has worked really well. People are going, what? Why can't I sit? And then at the end of the day, you go, it was really a good idea to kind of put me with other people so I could talk to other people. So basically, we brought those folks together, put them at a table together, and as part of the training day, we had them talk about their process, their programs, their eligibility criteria, as well as go over some of the issues of how do you work with these mothers and children, and what's the impact on the children of these different substances. So that's part of the in-person training day. And we also provided them at the end of the day with a list of everyone who was in the room with their contact information so that they could actually kind of call and contact everybody else who they sat in the room with and who they talked with. So the whole idea is that we needed to provide that communication. So what we've done is this multidisciplinary training for home visitors, child protective services. Actually, some of those are really not child protective services anymore. They don't call themselves that. They call them family preservation units. And that's where DSS is at the present time, is really struggling to keep families together. That's the goal. And you'll hear later from Jocelyn Gaynors, who is another one of the people who have been on our videos, about how that really is critical in terms of working with these women and children. And this is no mean feat. It took the leadership of these groups to kind of come together, because this represents 3 different state agencies. So we're talking about MSDE, MDH, and DHS. To make this happen and to kind of get people from these regions, from their programs, to come to this training. So as I said, there's 7 online modules and 1 full day of training. Currently, we've had about 200 and almost 300 people trained regionally, because we're doing the regional training so that they get to know people in that region. And that's the breakout of the different subgroups of people who have come to these trainings already. Okay? The evaluation of this program was the likelihood to collaborate with other programs in the next year, pre-test to post-test, was significantly higher. Okay? So just bringing them together, having them talk to each other and whatever, really increased the probability that they saw themselves really collaborating. And many of them kind of said, oh, we need to kind of do this. We need to kind of get our OB nurses and stuff into this group that we're going to talk about, okay? So the most helpful pieces of this training day, opportunity to interact with other providers, being mixed in with staff from other agencies, developing more collaborations, having contact information and services, and the information about the other programs. There's a lot of misunderstanding about what the other programs do, what their eligibility criteria are, and what it takes to kind of get into those programs, and what their mandates really are. So we did that with those 3 groups, but who else is involved with these women? Well, there's obstetricians and nurses, there's social services and social workers, there's addiction specialists, psychiatrists, peers now. Peers are really becoming very important in most of the health departments around the state, and in most behavioral health programs around the state. Obviously, you have the NICU providers, and you have Dr. Wally here who will talk some about that, and you have the pediatricians. You also have the judges, the courts, and the jails. Sometimes those can be helpful. And you need to kind of bring them into your perspective, just as you were doing. There's WIC services, other social services. There's also primary care and family practice and specialist care. And there's a lot of mutual help programs out there. As Rachel said, she used AA, NA kinds of programs, but there are others, Smart Recovery, other programs around. And again, I think the issue is some of that is really easy to access in the larger counties, a little struggling and harder to access in the smaller and the rural counties. So we do need to kind of think about how do you build those systems, and I'm really glad that you saw that system can work in a small rural county. Okay, you don't need everything. So our message to the providers is it takes a village. You need all of these people working together to do that. And again, I want to kind of emphasize that the SAMHSA's working definition of recovery from both mental health and substance abuse is this. It's a process of change through which individuals improve health and wellness, live a self-directed life, and strive to reach their full potential. And I think the videos you've seen of the people that so far are showing you that that recovery process is possible, and it's really important that people go through this. It isn't always easy, and it isn't always without bumps and curves, and it's a bit messy. But it happens. And I think people often give up on substance users, give up on people that they believe, oh, they can't change. No, that's not true. People with addictions change. Many of them change. There's no question about that. Some die before they actually can change. But we need to kind of reach out to all of them in terms of working through this change process. And the SAMHSA website has a whole handout that you can bring down that talks about what's needed in recovery and talks about all the different aspects of quality of life and also what is a recovery-oriented system of care. We should not be building treatment programs. We need to be building systems of care. And that's really the key here. So recovery-oriented systems of care is not simply, when you talk about recovery-oriented systems, recovery is not simply an absence of symptoms or substances, okay? It involves wellness and health. It involves integrated care that's comprehensive. It involves having meaning in your life and being able to cook meals and take care of your child, as well as kind of having a sense of I need to be off these substances and I need to rebuild my experience of life. Okay? So systems of care must be responsible to the multiple needs of their consumers. And you need open rather than closed systems. Okay? We have a lot of silos. I mean, if you look at NIH is basically a siloed system of research. I mean, many times it's either characterized by disease or it's characterized by organ part. So we have the National Institute of Kidney Disease and Disorders. We have the National Institute, and sometimes it's even the National Institute for Alcohol, but you also have the National Institute for Drug Abuse. So we have a lot of siloing of services, and the needs aren't siloed. So the services can't be siloed. So why do we want integrated care? So you need to treat people, not diagnoses. So you need to treat the whole person. Pregnant and parenting substance users have multiple challenges. And recovery involves a lot of different changes. And it's complicated by the problems and changes needed in multiple life domains. Some of these moms don't know. I talked to one pediatrician who said the moms really sometimes don't understand the babies. So that basically she gave me a story of, a mother kind of talked to her and said, my baby hates me. I said, well, how could your baby hate you? It's only a baby. Well, when I bring her up and I hold her, she tries to bite my face. Obviously, we know that's normal rooting behavior, but she's partly probably the guilt and partly kind of misinterpreting the cues from the baby makes for a challenge. So we need longer term. We need people in the homes. The home visiting programs can last up to 2 years. Infants and toddlers programs usually go till 3, and then they move on to early childhood, some other kind. They pass these kids off to other programs that actually work with these children. So it's really important to kind of have this process. So the other thing is we, the healthcare providers, can be overwhelmed when we're facing this reality. And what we do sometimes is hunker down and do what we can do. I only can focus on this part, so I'm only going to do this part of it. I'm not going to really worry about that part because that's the only part I have control over. But you have to be thinking integratively to be able to kind of do this work. And the other aspect is there's hope and strength in a team approach. So teams are stronger. I know you may be a wonderful individual provider, but I think still teams are stronger. So if we talk about integration in the new healthcare system, these are the kind of key elements. Do with, not to. Okay? So that's an important just piece there. You're doing it with the person, not to the person. Chronic conditions always involve motivation and behavior change. So you've got to engage the individuals, you've got to get their trust, you've got to help them find their internal motivation to make the changes that we want them to do for their care and their recovery. It's got to be multidisciplinary. The problems are multidimensional. You need a multidisciplinary perspective on how do you deal with these individuals and their families. Okay? The system must be blended together in order to achieve the goals of integrated care. You need collaborations. How and where services are offered and how information is integrated is critical to collaboration. And finally, we need to be thinking about using some new technologies. I mean, how can we find and use the new technologies that we have access to, especially to reach out and extend services to where the patients are, especially if it's difficult with transportation, if you've got a lot of barriers, how can we actually kind of connect with them in meaningful ways using technology? Okay? We have thought, and this is not a new idea, lots of people have talked about kind of we need case management. So I've kind of promoted case management in other places, but when I think really about case management and integrated care, I think there are some differences that are really important. A lot of times the case manager is given the responsibility to be a manager of the programs and the services. They try to link patients to various providers. They are affiliated often with a single provider, and they are trying to contact others. And they have inadequate resources. Whenever we're doing these trainings, I say, well, what's the thing that you need the most? They go, housing. That's what they don't have. So if you're a case manager and you don't have access to the housing resources, there's no way that you can really be helpful. And so they try to coordinate and integrate, but often that's seen as the case manager responsibility. So I think integrated care is somewhat different. It's a coordinated approach to address the person in light of the multiple complicating problems. You need a team of providers working together, linked by the client's needs, that the client should be at the center of this. You need a reciprocal communication and referral flow. That's got to happen relatively seamlessly because otherwise people get lost. And then everyone's responsible for integration, not just one person who's the case manager. So I think that's really the goal of where we're going if we're talking about interdisciplinary collaborative work, research and services for these particular women. So an effective system of care is not siloed, client-centered, accessible, coordinated, integrated. That's really what we want, and focused all around this mother and child, or children, our family. We need to think about that. So I asked Rachel one more time, kind of, well, what do moms need? And this was her response that I wanted to share with you. And I want to thank her for being courageous for actually doing this video for us.
Yeah, empathy, caring, a push, when needed, knowing when to empathize and knowing when to push forward, because it is work and it is hard, and you are learning not only to be a mother, but you're learning to be yourself all over again, if for the first time. A message to another woman. To stick and stay. To stick and stay, it's scary, it's overwhelming, and it's hard, but it's worth it. It's worth going through all that pain to experience the blessings of your children walking for the first time, or your children talking and saying your name, or seeing you pick them up from daycare and their eyes light up. It's worth that alone, but also the internal gratification of knowing who you are and being spiritually whole. It's worth every journey that you have to take to get there. So stick and stay would be what I say.
Yeah, so that's her message to other moms, and that's a message that I think we need to be working with and creating as well. So I'm going to finish with just this kind of a comment. What's the secret to success? It's CCI, okay? It's collaboration, 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 okay? It's communication, 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 and it's integration, integration, integration. And that's really, I think, what I think our systems have got to go. And I'm really pleased to see so many people from so many different places coming together to really think about this. This one-day workshop, though, doesn't do it, you know. It tells us, it identifies some of the issues and some of the things, but we need to kind of really figure out how to build bridges, how to build connections, how to make the collaboration, the communication, and the integration work. And there are a lot of barriers to the communication. I mean, everybody from CFR 24, from the behavioral health folks to the HIPAA and all of the other kind of things say, oh no, I can't share this information with you. I mean, what I also have learned is that basically the information of whether the child was exposed doesn't get to the people who get to the school level. They never know that this was a child exposed to having neonatal abstinence syndrome unless they have a good kind of system of collecting data and they have a good intake process and they talk to the mom and they get all of that information. But a lot of times some of the kids who are having problems in school, at least we may understand those problems a little bit better, but the communication doesn't get to the next level. The communication doesn't go from one group of providers or specialists to the other group. And that's easy to solve. You get permissions. You ask the client to kind of share this information, and you share what information you think is really important to be able to integrate care. You can't integrate care without good communication. You can't build good collaborations without good communication. Thank you. We have a couple of minutes if you want to ask any questions. Yeah.
First off, great presentation. Thank you very much. I'm going to make more of a comment about collaboration.
Sure.
So I think a lot of times the issue that we face is that we care very much about what we do. And priorities to us, automatically, we think are going to be priorities to everybody else. And that's not the case. And it's not because of indifference. So I'm going to give a slightly off-topic example that we started a program with immunizing for the flu in our public schools. Well, to us, preventing kids, especially with asthma and diabetes, from ending up in the intensive care unit was a priority. And it's not that the schools were indifferent, but their priority is education. Right. So we had to frame it in a way that was important for the schools. And what's important in the schools is standardized tests. So when 20% of the kids are absent from a class, that doesn't look good. And when they have a half dozen teachers that are out sick at the same time, that's a problem. So our pitch to the schools was not keeping kids healthy. Our pitch to the schools was it was going to improve their attendance. In turn, it was going to improve their test scores, and it was going to improve for their staff and their problems there. And all of a sudden, boom, we were into the schools and we were doing what we need to. So I would just encourage all of you, we all, in the end, want the same thing, but sometimes from different perspectives, you need to sometimes put yourself in other people's shoes, but sometimes it's just sitting down with your one colleague from a different field and understanding from their perspective that they have mandates from the state, they have mandates from their hospital administrator, they have mandates from whomever, and then how do you link your priorities with what should be their priorities?
So I will tell you that that actually is a wonderful example of using the stages of change, even though he never said the stages of change there, but getting somebody from pre-contemplation to move them toward action, which is what you have to do with these systems, is the same thing as you do with individuals to get motivation. But you get motivation by finding their motivation, not by imposing your motivation on them. And so that's the process of really kind of figuring out where that motivation is, linking it there, getting them to do a decisional balance that looks like, hey, this is really in my best interest to do this, getting a plan of how you can do that, getting them into action, and then maintaining that over time. And that's really what the process involves. And if you're going to be working with other groups, it is finding out what their values are, because that's what's going to motivate, not imposed values from other people. Any other? Yes.
So I can project. So I was wondering, you were commenting on the collaboration with schools, but I also want to think about some of the lessons from the 80s and the crack cocaine epidemic and some of the what we know about the mechanism of NAS versus the comorbidities that come with NAS, and balancing sharing that information with also not stigmatizing those children.
Right.
So I'm wondering if you could comment on how to make those decisions.
So again, I think it's really a challenge to kind of talk about all of these things. But if you think about it, I mean, my daughter actually works for understood.org, which is the National Learning Disabilities National Association. And understood.org is trying to give information about all kinds of problems that people have. 1 in 4 kids has a learning disability for whatever reasons and whatever kinds of things. So we need to destigmatize learning disabilities to kind of look and see, well, what's happening? Many of these substances that kids get exposed to affect the neonatal abstinence. You have also the kind of affecting the soothing part and the ability of the child to kind of do those. But later on, it really affects self-regulation. And that's really where you need to be looking at to do that. So again, I don't think we need to be saying you're exposed to this child has a risk for self-regulation issues that are going on. Some of that may be kind of from physiological or other kinds of things. As we know, ADHD is also genetic. So there's a genetic component to that. So we need to be thinking about those kind of things. And so we don't want to stigmatize, definitely, but you want to kind of get information that might be helpful. Or people stigmatize these kids as acting out, externalizing disorder kids, and then they get kind of put on the side somewhere instead of kind of understood that, wait a minute, let's look at this child a little more depth. That would be my question.
Thank you very much, Dr. DiClemente.
All right, so we're going to load the case that we're going to be discussing in just a few minutes, but we'll get started in the interest of time for introductions. So again, my name is Becky Vivrette. I am an assistant professor and clinical psychologist in the Division of Child and Adolescent Psychiatry here. I primarily work with infants and young children and their parents. So we have an exciting panel here today and a case that we're going to go through and have some case-based discussion and some time for questions and reflections from you all about this case that a couple of the folks on the panel actually worked with. So I'd like to just start with introductions of each of our panel members. So if you could each just briefly introduce who you are, where you work, and what your role is. And also perhaps if you could comment on what you see as some of the critical issues facing you in your interactions and your role with mothers with opioid use and their infants. So why don't we just start with Chris and go down the line.
So I'm Chris Welsh. I'm an addiction psychiatrist here at University of Maryland and have been working in opioid addiction and specifically with pregnant women since, I guess, 97. And just hearing Dr. Polsky reminds me back in the late 2000s, early 2010s, because there was no one in Calvert County, I had at one point, I think 5 or 6 pregnant women from Calvert County who were driving up here to see me in Baltimore. And I think I had couple dozen over those years, so a big issue. But my role here, I work both in outpatient, so one of our addiction treatment programs here, and then I also run a consultation service in the hospital where we interact with people when they're admitted. So we'll be hearing about the case, a case that we had that was admitted here, but.
And then the issues that are facing you, some of the big challenges and issues that you think are facing you as a provider in your work.
I mean, you've already heard some, and as a provider who really pushes using medications, methadone, buprenorphine, being involved with both. So just interacting with a lot. I mean, we've heard about stigma, but the stigma isn't just the general public. It's stigmatized. Many of these women struggle themselves with issues, their family, other people, the general public, other healthcare professionals. So the biggest issue is just trying to work on that. And we talk about it as though it's terrible now and things are really bad, but I've been doing this for over 20 years, and amazingly, things are tons better than they used to be. As Dr. DiClemente talks about, it takes a lot of time for individuals to change. Obviously, it takes even longer for kind of public acceptance and system kind of things. But just seeing, like, in the more rural counties, the things that are happening now, that would have never been the case 10 years ago. So I think it's important, as frustrating as a lot of these things are, things still are a lot better than they have been.
Hi, everyone. I'm Kelly. I'm the inpatient social worker on labor and delivery and the mother-baby unit here at University of Maryland. Sorry if I'm speaking too close to this. My role in the unit is pretty diverse, but I work with patients on a wide variety of things, and specifically with women with opioid use disorder. A lot of times I work with the medical team and with the substance use team with Dr. Welsh on getting these patients into treatment, trying to look holistically at each patient and what that person is dealing with in their life, getting to know them, and how we can improve their outcome, minimize their risk. A lot of the barriers I work with have been touched on today. A lot of times I'm the person that, whether it be one of the doctors, the nurses, substance use team comes to, the patient themselves is, for example, housing that's been touched on today. They might say, like, this person is homeless and they're 35 weeks pregnant and they've got an opioid use disorder, and we need to look at that picture. And then we've got maybe, for example, they've got a partner involved and they don't want to be separated from that person. So a lot of times I'm navigating the vast, very diverse social issues that can come up, and just trying to work holistically with the team to come up with the best plan for these patients.
Hi, I am Katie Mark. I'm an OBGYN. I apologize that I keep looking at my phone. I'm actually in charge of our whole service right now, so I'm not trying to be rude. Just want to throw that out there. So I am a full-time clinician, and I also do research in the area of substance use and pregnancy. I'm the medical director of the Women's Health Center on Penn Street, and my role is to take care of women over their entire lifespan. So a lot of our care ends up being obstetric care, but we see them prior to pregnancy for preconceptive counseling, for contraceptive visits, and after pregnancy for postpartum care and really lifelong care. So, and I work very closely with Kelly and Chris and the substance use team and social workers, because we have a very high needs population, whether that be substance use or also all of the other things that come along with that, interpersonal violence, mental health disorders, housing, those type of things. I think that some of the biggest things that we're currently facing, I mentioned a little bit in my talk earlier, and everybody has mentioned a few times, the biggest one, of course, is stigma, and the fact that when women actually get to me, they've already made a lot of steps in the right direction, because a lot of women are very afraid to present to care because they're afraid of the judgment or the stigma, or really their own internal demons that they present later to care because they had late recognition of their pregnancy, but then they also have sort of been in denial about the fact that they're pregnant. One of the quotes that Dr. DiClemente put up earlier about a woman saying she knows she's a bad mother just really broke my heart, because being addicted and struggling with addiction doesn't make somebody a bad mother, but they believe that they are, and they were going through this struggle, and now they're pregnant, and then they just have a lot of self-doubt and guilt in trying to empower women. And I also mentioned this earlier. I know that there are people here from the state and from social services and things like that, and everybody's goal is to empower women and help them, but the women that I work with have had a lot of negative interactions with authority figures, with people that are supposed to be in place to help them, and so they are very distrustful for understandable reasons, and so they're afraid to come see us because they think they'll be reported, and then they come see us, and then we tell them, yes, you will be reported, and that is really a horrifying place to be in, because we never report anybody during pregnancy, but as I mentioned earlier, if a baby is born and withdrawals, even though I know that it will, and I tell the mom that it will, there still has to be a report made. And even if that baby isn't taken away, that is extremely disruptive and also offensive to the woman, that she's doing everything that she's supposed to do. So just, I think this is a very long, drawn out way of saying that one of my biggest things that I face every day is trying to build trust in a system that there are a lot of reasons that women don't trust, a lot of really valid reasons why they don't trust. So we just all try to work on that together, and I think this sort of integrated model of care is really good, because pregnancy is the most obvious place that you can see where this all gets disjointed. Like, you're a 24-year-old woman, and then now you're a 24-year-old pregnant woman, and this is very different, and there are different services and different people available to you and different things that we care about. And now you're a 24-year-old mom, and those, now your doctors that you saw before may be totally different. All of your support system is different. Maybe we take your insurance away because you're not pregnant anymore, and the implication there is that we only cared about you while you were pregnant. So trying to convince women that we do care about them when the system isn't really set up in a way that seems that we do is challenging.
Hey, I'm Dina El-Metwalli. I am a neonatologist, clinician, and a researcher. I'm the medical director of the Neonatal Intensive Care Unit, which is a level 4 unit and the biggest unit in the state of Maryland at 52 beds. My research area is outcome. I work with environmental modifications. I work with music. I play music to the babies. I look at their brain development. And 5 years ago, maybe 2014, 2015, I started getting interested and looped into the problem of neonatal abstinence syndrome or neonatal opioid withdrawal syndrome. We see the other side of it. It's very interesting to me to be sitting among this crowd and listening to the wonderful presentations by everyone, a lesson to be learned, whether it's a success stories, as Dr. Polsky has shared with us, whether the maternal side, again, Dr. Mark has shared, and we don't really see it. But it's also interesting to listen to your experience, because I ran workshops at the Maryland Judicial Courts to judges, and listening to judges in the workshop is like, from their perspective on how they see things, is very different. And this is an example of a silo. They are out there, they are listening to us for the first time to tell them how those babies do, and how to look differently at mothers. I did the same, did some worship training with infants and toddlers, and I learned a lot from their experience, but follow-up is short-term in a way. Readiness at 5 and school teachers, when I was in this workshop, I learned more and more. So every time I'm in one of those workshops, I'm learning something and I'm putting pieces together, which really makes it very complex for babies exposed to opioids and other polysubstance exposure. My recent work, which I'll be sharing with you, is really, to me, is amazing. It changes a lot of things. And Dr. DiClemente has mentioned genetics. We are, for the first time, are looking at genetics profiles, and I would love to share this with you. We are looking at things that nobody looked at. We are putting together predictors for how long those babies will stay in the NICU, who needs pharmacotherapy, who needs one, who needs two. And although it is preliminary evolving data, but I think it is very promising, and I'll be sharing more with you why it is promising.
Hello, my name's Lorraine Milio. I'm actually the outsider here, coming from Johns Hopkins. But I'm OBGYN and maternal fetal medicine, and over the last number of years also boarded in addiction medicine. My background originally, before I got involved in addiction medicine 17 years ago, it's hard to believe, was really in diabetes and in global health. And both of those have really helped me really look at substance use disorder in pregnancy from a different angle, seeing it like diabetes as a chronic disease, and that if you don't teach the patient self-management, they're not going to have long-term success. And from a point of view of global health, I find that, I could more easily survive in a village in India than in a crack house in Baltimore. And so really understanding that people are, coming from a very different perspective than I am really has helped me in terms of having rapport with patients. I'm the OB director of the Center for Addiction and Pregnancy on the Johns Hopkins Bayview campus, which is an outpatient program that also has a housing unit. And I'm a co-director of the HIV and pregnancy program at Hopkins Hospital. I also coordinate a lot of the substance use disorder care among the pregnant women on both labor and deliveries, and do consultative work around the state. Some of the real barriers to care have somewhat been already talked about. I think stigma is certainly still a big thing, and really sometimes starting in the healthcare system, and then going out to the larger society, the families of even the patients that we see. And that's a real obstacle that takes a lot of work. And as one of my pediatric colleagues said, these women are largely survivors. And once I introduce students and residents to the fact that these are really people struggling with a disease, it really makes a big difference in how they view this whole clientele. I think coordination of care is a challenge. It's really nice to talk about, but when you really start to work with people from other disciplines, you realize that there are different philosophies of care, different philosophies of approaching patients. And it really takes a lot of work to understand and mesh those different philosophies to optimize care. And lastly, I think realizing that these patients are not one type of patient, and we take patients who are coming who are really ready for recovery, and they don't use drugs the day they come into our program. And then there are other patients where we spend their entire pregnancy getting them ready to start recovery, and trying to have deal with a mixed population is an everyday challenge for our staff, because we take women who are at all different phases of from pre-contemplation to really wanting to carry through, and we really have to have the patients be cohesive on one hand, and yet understand what their individual needs are. And I would say lastly, one of the things, of course, I know the title of this is Managing Maternal Opioid Use Disorder, but I think there's all the money, all fingers going into opioid use disorder, but we have to realize that opioid use disorder doesn't happen in a vacuum, that we still have a lot of other substances involved. And I've had patients who've had serial substances. They get past their alcoholism and then they turn to opioids, et cetera. And so I think while we're focusing on opioid use disorder, we really have to think about the whole package of alcohol, cocaine, opioids, benzos, et cetera, in one fell swoop and not isolate them.
Thank you, everyone. I think that was a great example of the range of perspectives that we have to discuss the case, which we'll do in just a few minutes. But I think the thing that I was struck by in listening to each of you the most is how much each of you talked about stigma and taking the family or the mothers or the infants even perspective in this. And I think that's a very different conversation than we may have been having 10 or 20 years ago as a field and in systems, and really working to partner and be able to destigmatize a lot of these issues. So that's wonderful. So I'm going to bring up Dr. Welsh now to, if you want to talk about it from here, to go through the case. He is most familiar with it, so I'm going to have him lead that, and then we'll engage in some discussion with you all and with one another.
So what I'm going to do, I'm going to talk a little bit about her history and then go through kind of the timeline of her engagement with University of Maryland medical system. Much of this is kind of skeletal, and I'll talk about this as we talk about when she was here with us in the hospital. For different reasons, she was extremely irritable, hard to get much history from at all. So some of this I had to glean going through CRISP, going through trying to find old records. I found an old, I'll talk a little bit about an old psychiatric hospitalization that had some of her history. I'll talk about it, but some of it is really secondhand from other charting. So this was a 33-year-old white female, her third pregnancy. Chronically homeless. Looks like she'd been homeless for a number of years, but homeless when she came here. 9th grade education, not clear whether she had ever gotten her GED, and it's not clear whether she actually may have some learning disability as well. Chronically unemployed, it looked like, for many years as well. She had the 2 previous pregnancies, 2 children that looks like were around 12 and 15 that were both adopted soon after she had them. Estranged from both parents. Part of one of the old records I could find looked like she had grown up at least partly in Calvert County. I think the mother may still be there. I think mother had a substance use disorder as well. But a lot of issues with her kind of social connectedness we'll talk more about. Her medical history, she'd had both of the previous pregnancies with C-sections. She's hepatitis C positive. Was not clear that it was ever treated, but she had an undetectable viral load during one of our admissions. She had a stroke in the past, and again, she's a young woman, so that was probably cocaine related that we'll talk about, but it actually affected her. She limped, she had, part of her, facial droop. So it made it, this woman who already had all these other issues looked a little bit odd, and I think that really did impact kind of how the rest of the world interacted with her. She had several prior abscesses and cellulitis in her arms and groin area from injecting drugs. Her psychiatric history, what I could glean from this one admission she had at Bon Secours last year, she's diagnosed with schizoaffective disorder, PTSD, anxiety, possibly a learning disorder. She'd had history of suicidal ideation and also auditory hallucinations telling her to kill herself. So that's what had led her to be admitted at Bon Secours I believe it might be on the next slide, but the Bon Secours record mentioned she'd actually been hospitalized at 7 years old psychiatrically. So it's not really clear what was going on then, but clearly a lot of issues. And it sounds like she had both childhood trauma as well as physical and sexual as an adult. She was followed over the years by different outpatient providers, but was currently in outpatient mental health treatment that we'll talk about. So that, again, we couldn't get a whole lot more history from her. So this was, again, a lot of what I could get from old records. So just going now to her interactions with us here at university. So she had actually come to the ED back in March complaining of bilateral foot pain. And again, she's homeless and just out wandering. And so a lot of it related to that. And at the time, she mentioned to the emergency room doctor that she had missed 2 periods, but she ended up leaving before they could do the pregnancy test. Showed back up in June, and now knew she was pregnant, was complaining of pain, was diagnosed with a UTI and was given Keflex, and again was just seen in the emergency room. And this was, I looked at the date, it was a Friday evening. It appears that she didn't want to stay. They tried to engage her. They gave her numbers for CAP, other programs, but being a Friday evening and it looks like her being inpatient and not wanting to stay, it was really hard to make any kind of an actual plan or a warm handoff. So it looks like she left with a paper with phone numbers and didn't follow up with anything. At the time, her urine was positive for methadone, cocaine, and opiates. So then when we really got involved was in August 13th when she came in, approximately 34 weeks pregnant, and we'll talk a little bit about that because that became an issue. She was convinced she was about a month further along, and that became a treatment issue here. When she came in, she was admitting she was using heroin, fentanyl, whatever's on the streets here in Baltimore now, and cocaine. The medications she was on at home were Klonopin, clonazepam, 1 milligram 2 or 3 times a day, and we could see in the PDMP she'd been getting that for at least 6 to 8 months. Looked like regularly. She wasn't going in early to get early prescriptions, so we don't have any reason to think she was misusing it, but she's on trazodone at bedtime for sleep, fluoxetine or Prozac, gabapentin for chronic pain. Some people also use that for bipolar disorder. And then she was on methadone 90 milligrams a day at Turning Point, one of the methadone programs on East North Avenue. At the time, she was, again, she's been homeless. She was living basically in an abandonmenium over there and had a male friend who lived, I guess, in a home, like a house with electricity, who kind of, it seemed, watched out for her. Even though it was an abandoned house, she seemed to have cats that she cared for. So at one point, she was trying to contact him to make sure he was kind of looking out for her cats that were in this abandoned house. And but that was about her only kind of social, Yeah. Why don't you get that? Yeah, Kelly can add in the.
Yeah, she was married, but her husband was incarcerated, had been for, it seemed like, a long time. So this neighbor, who me and Dr. Walsh actually got to meet briefly, kind of looked after her. When she came in, we were kind of like talking about treatment, which we'll get more into. One of her big things, I mean, she wanted to leave AMA as well because she was concerned about her cats. She loved her cats. So we were helping her to get her phone charged so she could get in touch with her friend so that he could go, she could take care of the cats, and then he came and actually visited her and kind of like reassured her on that. She felt good after that about her cats. Yeah.
So with this first admission, and again, some of the things I got cut out of the slides, but she had actually been taken initially to Midtown Hospital by the police. And we couldn't really find was she actually under arrest because they did not stay with her. It wasn't clear what was going on. It turns out she had some open warrants. But that also became part of the issue later that we'll talk about. But you know, the baby was otherwise doing fine, and so once we got her stabilized, so what we did while she was in the hospital, because she was, you know, still using heroin, and it turns out that her methadone program, if you're using either benzodiazepines, even if prescribed, they won't raise your methadone dose above 90 milligrams, and we can talk about that, and we can talk more later about the clonazepam being prescribed in the first place, those kind of issues, but she really did seem to think it was helping her in her, you know, various psychiatric conditions. But she'd been on methadone since before she was pregnant, and they had not raised her dose later in the pregnancy, which often we need to do, especially in the third trimester, and often split the dose. So we just decided here that we would at least raise it. You know, we raised it 10 milligrams, and then I called them and told them we had done that, and they agreed to keep her on the 10 milligram higher dose. She probably would have needed to go even higher. So then the big issue, as Kelly's already alluded to, is what do you do with a homeless pregnant woman later in pregnancy, because a lot of places won't take somebody this late in pregnancy, on methadone, which already limits a lot of your options, and then adding on the clonazepam, there were virtually no options. So Kelly spent, I mean, dare I say multiple hours, it was probably a day or so, on the phone, calling every place we could find. We finally found one that agreed to take her, this community wellness center. They said that they would let her stay on her clonazepam, they just wouldn't let her see her own psychiatrist. She'd have to see their psychiatrist. So, 5-6 days after she came in, she went to that program. And then a couple days later, Kelly got a call from the patient that it sounds like she'd only been there a day or two, and they would not continue her on her clonazepam. And so she left with no real plan. So Kelly got a call when she went to her methadone clinic and got robbed there. And she had just been in the interim to see her psychiatrist, got her month's worth of clonazepam, and was robbed of, you know, whatever belongings she had, but also all of her medications. So she called Kelly. Kelly told her to come in to the hospital. So she came back in on August 21st. And at that time, she'd had an intrauterine fetal demise. So we don't really know, was it the fact that she went back out and used when she left that program because they wouldn't do what they said they had done? We don't really know. But when she came in this second time, she was very sedated, very uncooperative, would barely talk to, even Kelly and I would spend a lot of time with her, you know, the previous week. But we could get enough, you know, out of her to find out that. But then it was, what should we do? You know, what do we do with the fetus, the different options? For about a day, we couldn't even talk to her enough to explain the options, to get her to give informed consent as to kind of what procedure to move ahead with. But, you know, finally she did. So the team went ahead and delivered by C-section and did a tubal ligation on August 25th. Just have a little bit of, again, because she had had a C-section, so the post-op pain management was kind of rough for a few days. Again, she's very, very anxious and didn't have a lot of frustration tolerance, so really struggled with the pain for a couple days. But, you know, ultimately did okay with the initially the PCA and then oxycodone. So then we had another place, and now she was no longer pregnant. They were willing to take her on both the clonazepam and the methadone. And so we had a plan. They wanted her at like 9 or 10 in the morning to be at this place. So the problem was that she had been robbed, and the clonazepam, if people aren't aware, opioid withdrawals are really like a bad flu. It's really miserable, but most adults aren't going to have, die from that. With clonazepam, you can have seizures and die. And we know she was taking it because we were giving it to her here in the hospital. And so I just decided that I would write her a prescription for a week or two till she could get back in to see her psychiatrist. The problem is that her insurance had just paid for a month's worth the week previous. So Kelly worked with the social work department here and agreed that they would pay for this, the week or two amount. So then I wrote the prescription, and then probably 4 or 5 hours later, I hear from Kelly that the pharmacy was refusing to fill the prescription, even though they knew that we were going to pay for it. No one, and I don't know if Fadi is still here, as we were talking about the collaboration, so no one, and this was our pharmacy here in the hospital who knows me well, no one from the pharmacy had contacted me to ask me what was going on. And so they were like, well, the pharmacist was worried about her license and the risk of giving somebody a Klonopin prescription with methadone. And I said, well, yeah, but there's also the risk of her having a seizure and dying if we don't give her the medication that we've been giving her here in the hospital. So we went back and forth with that. Then the social work department went back on their initial agreement to pay for it. They were saying they were now worried about the liability and risk. And so finally got them to agree, but by this time it was after 5. So she had to go to, initially she was supposed to go to a central office that then would take her to her housing. That was closed. So then they told Kelly to have her go to a different place. And the story is, as far as we know, she never made it there because everything got so messed up, mostly that last day because of internal issues here around, again, a complicated case, but things that we should have been able to deal with better, I think. So, anything else you can think to add to her?
Yeah, I mean, that's the general picture. Dr. Welsh and I were working hard that last day to get what I felt like should have been a very quick thing. I mean, he wrote the prescription, we were going to pay for it, met a lot of barriers that kind of drew out when she could be discharged. And learned a lesson myself from that, that a later discharge is really not, it's just better if it can happen, I think, during day hours when we're here to continue to manage that. But yeah, it kind of changed up the plan. She was going to no longer be going to the intake office because that was closed. So I had called the house, the managing of the different houses that they had for this particular program, the supportive housing. They'd placed them in different ones, and called that to say, look, it's going to be after hours. You said it would be a different address I would send her directly to. Got that address, and we're not really sure what happened in between, but she didn't make it there. I sent her in a lift to that address, but so that was pretty rough.
So part of why we brought this case up was just the different systems, the difficulty with multiple comorbidities, that we really just don't have a very good system. And we probably have a better system than many areas do, but it's still, grossly. And then the whole, when she came back in the second time, I ran into Kelly, and the team had called me to say, Miss So-and-so's back, and I was running up to see her, and that's all they told me was Miss So-and-so's back. I didn't know that the fetus had died, and I ran into Kelly, and she was upset, and I didn't know at the time what she knew, and I just thought she was angry that this follow-up place had not done what they had said they would do, and she had spent so much time. I didn't even know yet, why, what was really upsetting to her. But I think it's just something that I'm sure everyone who works in this field, no matter which piece of it you work in, we face these kind of issues all the time, and dealing with all the issues that are already there. the things, again, that we couldn't even deal with internally that seemed like they were simple. But then really the toll that obviously puts on the mom and everyone, but also the treatment team, I think, is really important for us to talk about. So. Do you guys have questions about the case first before I sit down? Yeah, the other thing is, so the pharmacy wanted a police report. And so the two issues, one, she had an open warrant and actually did a case search on her. Her last warrant was from 1.5 years ago, and it was for consuming food on the MTA. It's ridiculous. But that was her last warrant. But the other thing is that it was a man and 2 women from her methadone clinic who had robbed her. Obviously, you know who she is. So she was afraid if she did a police report, they might actually, I mean, the police probably wouldn't do anything, but she was afraid they might go to her program and start questioning people, and they would know that she had ratted them out. So,
Has there been any changes in implementation based on this scenario, based on policies and procedures?
I mean, I don't know. I mean, I've talked with the pharmacy about, you know, if you have a prescription you question, especially if it's an internal doctor, you call them and talk to them about rather than just refusing something. But, yeah, but this just happened in August, so we haven't, like, had a lot of time to deal with.
I just had a quick question. What was she admitted for in the admission just prior to the delivery?
The first admission that we saw her?
Yeah.
That was what we were not clear, because she was taken to Midtown by the police. So we're not really sure whether they just found her out on the streets or.
Was she on the L&D service?
Yeah.
Oh.
She was brought by the police, because, is that what you said?
Yeah, but we're not really, I don't know if there was necessarily a medical. I think they may have just found her.
This one.
Because it wasn't really clear. It didn't even appear she had gone. Sometimes if they're going to go to central booking and they're this far along in pregnancy, they'll bring them here to make sure the fetus is okay and all. It's
They
not
bring
clear
them
why she
basically-
went there.
Anybody that has to go to central booking, they bring here first, and then not infrequently, they bail on it. They bring them, and they're like, oh, she's going to be arrested, and then they ghost and say, never mind, she's yours now.
Yeah.
So it may have been, I wasn't there for this, but it's really common that people get brought in by the police for clearance before they take them to booking, and then it's like not worth their pay, the amount they have to pay a police officer to sit there while we do their triage, and then they just leave and dump them.
Yeah, but again, usually they would bring them here, so we don't know why they took her to Maryland General, Midtown first, so.
My question, I guess, it pertains to the PDMP, I guess, that with the prescribing, is that the reason probably why they didn't fill it, because they're only allowed to give a certain amount by a certain time?
So my opinion on this, I don't know who you're asking specifically, but I see this type of systems failure so frequently in obstetrics, and every time I go back to the individual or the system, the response is always, I didn't want that responsibility. My license was at stake, right? I don't want to prescribe her psych medications. I don't want to fill her oxycodone, her clonazepam. I know that you wrote it, but it's my license. And I don't mean to point fingers at this pharmacist. I think that we all have this very intense fear instituted in us that somehow we're going to get in trouble. I don't know of any doctor who has lost their license for reasonable prescribing. There are very many people that are extremely unreasonable and don't lose their license, right? And that's what I talked about before, how the opioid epidemic happened, or what contributed to it. But there's the same thing with this system of, we don't want to take women that are on clonazepam with methadone because there's some risk. Okay, but like what happens to those women then? And so I think that things like the PDMP exist for a very good reason, and I've been extremely thankful for the PDMP. But then the flip side is we meet these women with a whole lot of suspicion, and people come in and say, oh, I was robbed at my methadone clinic and they stole all my meds, and we're like, yeah, right, really? Did that really happen? Or even if we do totally believe them, still there's just barriers at every angle, and I think
So-
this is such a great example that we can't even fix it.
So you couldn't go to another pharmacist, you had to use that particular pharmacy at that time? Okay. Was it
Well, so we
issue?
don't, we had to pay for it, but then also, we can't like walk down to another pharmacy. So I think everybody on the team was doing a really great job to not just say, here's a prescription, good luck. They were legit trying to fill it and hand it to her and say, look, I prescribed it. I'm willing to prescribe this for the person. I'm going to pay for it. And then there's just so many different levels of places where this can get mixed up. And they're really well-intended people that are trying to do the right thing, but
Do you think further training would help them understand?
and this was my point about the pendulum slide at the end, is that I think our training now is focusing a lot on how to avoid overprescription and missing the point of legitimate prescriptions. That's my, I don't know, I don't mean.
Did she process the death of the child, of the fetus? How was that even taken into account with her and everything that was going on?
So I did check in with her about that, just to see, where she was at. I don't know also if not that this necessarily would impact like her processing and how she kind of dealt with that, how she felt with that, but I don't know if you touched on the fact that she did originally was planning to have this baby adopted. So that was like one thing to also note. That was like another kind of like factor in this case, is when she originally came in, she did say she would have this baby adopted. That being said, she had a lot of other stuff going on. I had tried while she was with us and while I was trying to get her placed into a rehab to also connect her with an adoptions agency, but she wasn't totally ready to meet with them, but that's just a little of a backstory. They were also trying, something I was navigating is after I discharged her, is this adoptions agency, Adoptions Together, was trying to reach out to her and meet with her at the community wellness center to kind of like initiate that process just to make it smoother for her when she did eventually deliver the baby. So when she came back, after she had, she was very disoriented, like we talked about it, very sedated, couldn't really process it with her at that time. I did try to check in on how she was feeling after they ultimately delivered the baby and when she started to get back to what I felt was her baseline mental status. And honestly, she didn't really engage in a conversation about that. I don't really know where she was at with it. She didn't on on the front that she was presenting seem to be reacting to it, but I honestly think that would be understandable in her circumstances, that it would be a complicated reaction on her part. Yeah.
I have a question for, actually for Dina. I know obviously with the grief issue with the baby not surviving, but Dina, if the baby had been delivered successfully and then assuming the baby would have been admitted to the NICU, I guess what would have been the key issues for you given this history, if this baby's admitted and this is what you know, kind of what your first steps are and what you're thinking about in managing, both on the medical side and the psychosocial side, because she came with so many risk factors.
So babies, when they are born, they go to full-term nursery first, and they score them if they have positive toxicological screens and or history of disclosure of maternal use of medication of drugs. They screen them every 3 hours, modified Finnegan scores. If they hit a certain number, which is, I'll be talking briefly about this, is 9 times 2, the baby is admitted to the NICU. Usually with opioids, it takes the very severe ones on very high methadone, they present earlier, but otherwise it takes around the 48 hours to come to the NICU. And some of them don't come. But if this baby comes to the NICU, this baby will be reassessed. We try not to jump to pharmacotherapy. We give it some time, which is usually, we need a lot of understanding nurses to do that. And then we try to engage the mothers. Because there is a lot of interest in looking into backgrounds and different factors, most of the babies, or almost all babies with neonatal abstinence or opioid withdrawal syndrome, we approach the mothers in the very early, like once the baby is admitted, sometimes before, to see if they want to be involved, they are okay to be involved in research. We don't do any invasive blood work. We just look into their demographics and stuff. In this particular case, one of the main problems that we face in the NICU, we are trying to change culture. We are trying to divert blame. We are trying to say, hey, because of many factors that we are studying, and here are our results from our own population, it might be beyond them. They need to be helped. We need to wait on pharmacotherapy. And it's not easy because the nurses are like, the baby is screaming. Can't we just start the medication? And I'm trying to hold off, and I'm trying to bring the mother in. And the mother is not ready. I have a whole cuddlers program, the CWIM program, the cuddlers for withdrawal infants. So we may have a call for the cuddlers for withdrawal infants. They come in. It's an opt-out program, like it's the default of the NICU. So we ask them to go in and hold babies and swaddle and cuddle and C-shaped and all the stuff that we do, and we actually videoed for Dr. DiClemente. But then the mother comes in and we're encouraging her. And do I have incidents of a baby slipping from the mother? Yes. So if they are out, and I'm trying to push this on my team, and the mom holds the baby, and she drops the baby, that's a liability for every single person in this NICU. And where to draw the line? This is a level 4 intensive care unit. We have babies who are preemies, 23 weekers, babies who are severely sick, and here I have this baby who's really sick and withdrawing, but I'm trying to say, hold on medications, give the baby a chance. I don't want to be treating opioids with opioids. How can we change this? And I have a liability of, the mother is not ready. I can't use her breast milk. Blah, blah. Again, I'll be sharing those slides with you. So we didn't have a baby who fell on the floor and had a problem. But I had a couple of incidences where baby slipped as mom was sitting on the on her nursing chair, and actually on a recliner, and the baby slipped in between the mom and the baby, the mom and the side of the chair. Baby's monitored, so nurses, they ran, and we had an incident report. We have a couple that we are writing up this. But can I say something? If we are writing 2 cases in the NICU of babies who slipped from mothers because they were on drugs, we have reported in pediatrics 6 babies that slipped from their normal mothers who are not on any medications during breastfeeding. Does it mean we should stop breastfeeding? No, no. This is not how we approach things, and we cannot just blame this on a withdrawing mother. It's definitely a higher liability. We have to have more eyes on. If the mom is holding, it's one-to-one nursing. We have to be ready for that. But a lot of things to be sorted and yet to go.
Maybe take one more question specifically about the case, and we'll open it. Okay, yeah, over there.
So you documented that the mom was connected to a methadone maintenance program, as well as she had an outpatient psychiatric provider that was prescribing her clonazepam. Was there any efforts to connect with those providers to see how they could coordinate this client with getting into prenatal care? Because I didn't see any reference here, and I just didn't know with discussions if they had talked with her about it early on and she was refusing, or what those efforts were.
So when she initially presented to us, she hadn't had any prenatal care. She was about 34 weeks pregnant. So our goal at that time was to get her not back outpatient, but I think we did have her scheduled for a follow-up prenatal care appointment here. We didn't necessarily work with those clinics. We did have her scheduled, and it was a part of her discharge instructions. And so the plan was for the community wellness center that was going to be housing her and doing her wraparound substance use and mental health services to also sort of manage that and, you know, remind her about her appointments and have her come to our outpatient clinic until she delivered.
So the adjustment of the methadone that happened post the L&D admission, the clinic hadn't already been treating her, knew she was pregnant, and made that small adjustment in the methadone before she was even known to you?
Can you?
They wouldn't do it.
You know, so the methadone clinic we talked to, they knew she was pregnant, and they had been trying to get her, but her life was very chaotic, and they're not going to say, well, we're not going to give you your methadone unless you keep a prenatal appointment, but they'd been trying. She just hadn't followed through. We had, you know, when she was here in June in the ED, they had tried to set her up, but again, she didn't stay, and it was a Friday evening, and so people had been trying, but you know, I think different places could have done more, it sounds like.
Dr. Milio had something to say. Yeah. If your mic is working down there.
Just wanted to address an issue that was at the very beginning that someone asked about the case, and that was about the, you know, robbery and reporting it, et cetera. And my understanding, and I've seen this in practice, like it's state by state law, but at least in the state of Maryland, when you report something, it's not uncommon for the police to come and basically do backgrounds on every single person in the room. And I've had patients who have been involved in domestic violence, been beating up, and they've ended up being the one arrested and put in jail because they had an outstanding warrant. I had a patient who I actually had seen on the news a couple months before she became my patient, who had been raped and beaten pretty badly right in downtown Baltimore in the day. And what the news didn't tell you is she ended up having an outstanding warrant for a failed court date she didn't know about, and ended up being incarcerated for a month without access to substance use care, et cetera. And so there's a major, especially when patients are homeless, there's a real major disincentive to report crimes against them. And it's a big problem, especially when there's a sexual assault, because number of programs that will house women who are victims of assault require a police report, and a lot of these women will don't file police reports and don't call the police, and that's a major problem. And my understanding is that's state by state, but that's the current status of things in Maryland as I understand them, and so that's a real challenge for us.
Dr. Mark, did you have?
I see a couple of people have questions. I just wanted to make a comment about this case, and kind of going back to what I was saying is one of my biggest frustrations in working in this field, is that I think that we in medicine know these things that come from legitimate research about women who have opioid use disorders may have these worse outcomes because of X, Y, and Z, or women who are homeless, or women who have mental health disorders. But what I see happen, unfortunately, is that people use that and turn it into a predetermined fate. And then it becomes a self-fulfilling prophecy. So this woman came to the ER when she was probably 8 weeks pregnant, and nobody did a pregnancy test on her, and she had missed her period. But they probably were just so focused, and I'm not trying to blame anybody, we all do it, but you're so focused on her substance use or her appearance of, having had a stroke, that you miss things that you would probably see with other people. And I see it happen so frequently when someone comes into the ER, everything becomes about their substance use, and then you miss the very basic medical things. I saw a woman once who came in, she was pregnant, and she came in and was basically unresponsive, and everyone assumed that she had overdosed, but she had a stroke that was completely unrelated, and they didn't scan her head, which is what would have happened if this woman wasn't a known substance user, right? And so the same thing, and I'm so glad that Becky brought this up about the crack epidemic, the same thing happens sometimes with these babies, is that you assume they're a crack baby, or they're going to have worse outcomes, right? But we don't always give them, and we do here, but we in society, I think, just assume this kid's going to have problems long term. And then when it does, we're like, well, we knew that was going to happen. Whereas there are often times that we can intervene and do things. And so the way that I see that the most in pregnancy is just, oh, she had a preterm delivery, or oh, her baby died. Of course it did. We knew that was going to happen because this is the outcome that happens to women that have these problems. So I think, trying to look at the holistic view of a woman and not silo it into like, you're a drug user, so this is what happens to you, or of course you didn't come to care until late. Well, first she didn't know she was pregnant, and then there were a million reasons. And the last thing I'll say about this, I'm sorry, I could talk about it all day, but the idea of refusal of care, I think, also gets really tricky, because I see very frequently, I actually just had this, and not a substance user, but it's a very similar example. There was a patient that called my office, and she was very upset at her inadequate care. And I looked back through all of her notes, and it was like refusing her diabetes screen, refusing this, refusing that. And I called her, and she was frustrated because we weren't coordinating her appointments well. And then she would come into her appointment, and we would tell her that she needed a 1-hour diabetes screen, but she had another appointment in 10 minutes and had to get to that. And then that was documented as refusal of care. And then she needed to know when her C-section date was going to be, because she needed her mom to fly in so that she could help with her other kids. And then that didn't work out. And so then all of a sudden she's refusing her C-section date, right? And so she gets in this loop of everybody thinks she's argumentative and just refusing. And of course she's refusing another thing. But actually we're not really helping her at all where she is get to where she agrees she wants to be in a better place where she gets screened and she gets her tests, but we're not getting that to her. And so, this woman, there were multiple times that we've said she wouldn't stay in the ER. She refused care. She left. Well, like maybe she was hungry, or maybe her cats did need fed, or maybe she, wasn't being treated well, or there were 700 other reasons that she needed to leave. But I think sometimes we forget to stop and ask, like, you're trying to leave right now, and I'm trying to help you. What is it that you need? Why is it that you need to leave the hospital? Is there something your kids need picked up from school? You have to get to work, or you're not going to be able to pay your bill, and then you're going to lose housing. But just this general like bucket of, well, they don't want our care, so what can we do for them, I think happens really frequently.
So we'll take a couple more questions. I just want to make a couple of comments. So one, in terms of the reporting issue, that it is true, right, state by state, and I would even argue as an early childhood psychologist, worker by worker, some of the practices change in terms of what the response might be. And then for those who are unaware, the CAPTA implementation has changed in the state of Maryland, where we weren't technically complying with the requirements of the regulation. And so now there is a huge uptick in the number of reports that have to be made, even if a woman is adherent to her prescriptions during pregnancy, if there are effects after the fact. That doesn't mean they go in out-of-home placement, but they have to go through a safe plan of care. And then the second part, with what Dr. Mark commented on about the long-term effects, also thinking about when those children then are engaging in systems like early childhood mental health, a question that we ask on our intake is, what's your hunch about what might be going on and your urgent concern for this child? And so many parents who have had substance use histories and mothers say, oh, I know it was because I was using drugs, or I know it was because of this. And they carry that shame with them for a long, long time. And that's not always the case. And often a lot of the research shows that it isn't. It's not the mechanistic effect of the substance itself, it's the comorbidities with the other things that have happened in life. And so I think that's a really important piece of the messaging and psychoeducation that we give to families who are facing that. So, okay, let's open it up. Yes.
I just wondered if peer support had been offered during that. I know you have peer specialists working at the hospital. Do you know if there had been maybe early on in the emergency room, or if it could have been helpful?
We don't have obstetric peer support yet.
But
it's only in the ER. So when patients come in when they're pregnant, we have our own labor and delivery ER that is not connected to the regular ER. And so I could not agree with you more that the peer counselors would be very beneficial.
Dr. Milio, is that something you have in your setting? Do you have peer support where you work?
Okay, so we do have peer support in our EDs, and that really has helped, and certainly there's some research data that has shown that when patients are, for instance, giving buprenorphine, if they're not on opioid agonist treatment even before they leave the ED, and have the peer support, that they have a much higher chance of reaching the next step or reaching the program that they're being referred to. So our emergency departments do have peer support. In our program per se, one of the things we find is even when patients call for admission, about half of them don't show up the first time. But if we reach out to them, about half that don't show up will eventually come in. So patients really need repetitive outreach, and that's been shown to be helpful.
I just had a comment besides with the young lady. So she had a very traumatic encounter. She's discharged, she's gone. Has anyone, maybe Kelly, have you followed up to see if she's back in the streets doing the same thing? Is she getting some kind of after postpartum treatment, counseling, care, anywhere?
So yeah, I do have her phone number that had been working for some time, and I have tried to call it multiple times, and it's just been going straight to voicemail. I never did get called. I did call her methadone clinic, and they were actually willing to talk to me, and I had asked that if I could be called if she came in there. Because I wanted to speak to her and let her know that she was welcome at the Divine Light that I had gotten her accepted to, if she still wanted to try to go there. And they said that they would put a hold on her case to have to speak to a counselor before she would get her next dose of methadone. I never did get followed up on from that, and I did reach out to Divine Light, the man who manages that. And he said he would do the same thing because he works with Turning Point a lot, where he would sort of call over there and put a hold in her case to meet with him. But yeah, I mean, I haven't heard from her, so seems like it.
Yeah, there's so much for you to hold, right? You are doing so much work, and kind of thinking of what Dr. DiClemente was talking about case management versus care integration. And what this case would even look like if you weren't part of the picture is hard to fathom, So yeah, yes, right here.
I just had a quick question. Given her psych history and unresolved grief, was inpatient psych care considered for this case?
Yes, it sounds like.
During her the first admission here, we thought about it, and she wasn't suicidal, but she was very frustrated, and but she did not want to stay. She didn't want to go to the psych unit, and she wasn't committable then. So, but it might have been a way to deal, keep her here and deal with some of those things. But like I said, though she clearly had issues, she wasn't certifiable at that time.
I'll just say too, there's only so much that can be done in an inpatient setting, and
Hello?
Hello?
Okay. Hello?
Doris, we can hear you in here.
There's only so much that can be done in an inpatient setting, and the capacity for our inpatient psych unit, I'm saying this, I don't know how to say this in the nicest political way, but we consult psych a lot for patients that come to labor and delivery with pretty severe psychiatric issues, and unless they are frankly suicidal, I'm going to walk out of here and slit my wrists, then they don't. It's incredibly rare that they actually get admitted. Mostly it's just referral to outpatient, not just, outpatient care is very important, but typically it's referral to outpatient care and coordination that way, because there's the capacity and indications for inpatient psychiatric care, I think, are pretty limited.
So let's just take maybe 2 or 3 more questions because we need to wrap up and we'll just do some closing at the end. So just the last few. Whoever has it. Yeah. Oh, there.
So I have one comment, which is this row, we are Baltimore County Department of Social Services, the substance exposed newborn units. And I'm sorry that some of your moms have had some negative experiences, but we work really hard to engage them in services. So I just need to say that.
Can I respond? I don't mean at all that you guys are doing a bad job. I really appreciate what you're doing. I mean that it feels like it's a bait and switch whenever we tell them to come in and then we're like, but I'm going to report you. And it's hard for them to believe that the reporting is supposed to be helpful for them. And so I know that you guys are working really hard and non-judgmental.
And we
so thank
do
you.
agree with the legislative issues behind that CAPTA law change. So that's aside from the point. I'm also on the overdose review board, and one of the statistics is that opioid overdoses is the #1 killer for pregnant women. And being on that board, we realized that the medical examiner's office does not gather that information. And you talked earlier about points of contact. And EMS also does not ask at an overdose if a woman is pregnant or could be pregnant. So I think that number is grossly underestimated for how many women of fatal and non-fatal overdoses are pregnant. And so I'm wondering what we can do to train our first responders, the police, EMS, and the medical examiner's office.
I'll take that. I actually sit on the Maternal Mortality Review Board for the state of Maryland, and you're right. I mean, substance use disorder is the leading cause year after year since about 2010, or one of the leading causes. And unfortunately, the leading time period is often after 6 weeks of pregnancy, somewhere between 3 months and 9 months postpartum. And it's very common for us to have all the records about delivery and then no records until whatever led up to their death. And so the postpartum period, the remote postpartum period, is after 6 weeks, is really a black hole in reviewing our records, and that's a major issue. And so it's very clear that it's what referrals are being made on discharge from the hospital or even at the 6-week postpartum visit. And in some clinics, I mean, half the patients don't come back postpartum, especially patients who have not had any or very scanty prenatal care. And so we don't really know what follow-up they've had, either from a psychiatric or from a substance use disorder perspective. And I think that's something that we really need to address. And in other cases, we've had patients where there have been multiple admissions to several different hospitals in the month or so prior to death, and no one has spoken to each other to pull things together, again, until the final situation occurs. And so I think there's a lot that, really needs to be done for follow-up afterwards, and rather than looking at pregnancy in isolation, really looking at these women over the course of lifespan and really being able to have a warm handoff somehow after delivery, I think could prevent a lot of these terminal events. But that's a big issue, and a lot of the confidentialities between the programs, although they have certainly a purpose, they really impede making sure that people have follow-up. So that's, I mean, you bring up a good point. That's a major issue.
Okay, we just have 1 minute, so very last question and brief response.
We could sit here and nitpick.
Oh.
We could sit here and nitpick this case probably for the rest of the day, but for all of us who work in this field, part and parcel are episodes of tragedy. And I think that fundamentally, that tragedy is a reflection of the rudimentary understanding we have of both mental health problems and substance use problems. The treatments we have are completely insufficient. I oftentimes liken it to treating metastatic cancer in 1969, so you go back 50 years ago. Your patients ultimately were going to come to bad ends. And so I don't think that our emphasis should be what else could have been done for this woman, because I'm not sure that anything that any of you or anyone else could have done would have been enough. But anytime I'm in a room with Senator Cardin, Senator Van Hollen, Steny Hoyer, my plea is more federal dollars for basic research to have a better understanding of mental health, substance use, and that nexus. We sit on the precipice with a lot of understanding of genetics that did not exist when I was in medical school, and a lot of other basic research that has put us in a position where with a real push, because my worry is that with emphasizing things like Narcan and all that, whatever comes next 10 years from now, it's not going to be of any help. And we're going to be no better prepared to deal with this than basically we were when I was in school and training, and we're still dealing with all this. So I would just implore, for somebody from a little county, I'm insignificant, but when you have a name of University of Maryland or Hopkins behind you, federal officials, they tend to at least listen a little bit more. So for any of you in the room, if you want a real project, to me, that's where the push should be, is influencing those federal dollars to go to basic research.
So thank you, everyone, for participating, and I echo, I wanted to end on a somewhat of a positive or action-oriented note, that there's a lot of things we can nitpick and talk about what went wrong with this case and many of the cases that you all have worked together on, but also how can we improve and what can be done, and a lot of that is at the policy level, so thank you for highlighting that. So folks will be here for lunch, but we're going to transition into the next topic. So thank you very much, everyone.
So the next topic is lunch.